is what you see, the actions by the nurse to manage and correct sequence, timing, and effectiveness of patient care. Collaboration is two or more people working towards a common goal. So not only do we coordinate, we collaborate. There are some critical differences. Coordination is initiated by the nurse. Collaboration may be initiated by the client, the family, other members of the healthcare team. Or it can also be initiated by the nurse. One of the things that you'll see is that collaboration requires direct interaction. That coordination may or may not involve direct client care. Remember, your case managers are care coordinators. But do they do direct patient care? No. So what you will find is that they will coordinate, but they also may collaborate with other members of the healthcare team in order for that direct patient care to be done. Now, some of the things that you will see that cause barriers to effective coordination of care is a lack of collaboration of team members. Well, if you're trying to do something and physical therapy that needs physical therapy assistance, physical therapy is not available, then your coordination of care is going to be blocked. A lack of resources, i.e., the patient may not have the money or the insurance coverage to get exactly what they need for the most effective care. So sometimes what you'll see is you have to do workarounds. One of the best things that ever happened was that $4 list from Walmart and Walgreens and wherever else came up with the $4 list. Because it now means that patients are more likely to be able to afford their medication. It's a whole lot of difference in $4 versus $40 versus $400. Doesn't mean that the meds on the $4 list are always the newest, the best, and the greatest, but they are effective medications. Often what you will see that is a barrier to effective coordination is a lack of interdisciplinary understanding. You don't understand what someone else does. You consult physical therapy for someone that needs a hand splint. Typically split, usually the way I remember, if it's lower extremities, it's PT. If it's upper extremities, it's OT. So, inadequate communication and then ineffective problem solving is also a problem that you'll see. You cannot think critically if, say for example, PT is blocked for this day at this particular time. You have to be able to problem solve that, well, I can't get this person to physical therapy at 4 o'clock on a Tuesday because they don't have a ride. Then you have to coordinate and collaborate. Well, they can go Wednesday at 9 o'clock because they do have a ride. So sometimes that problem solving is one of the things that you have to think. You know, in other words, if I had just said, well, you can't go Wednesday at 2 o'clock because you don't have rides and therefore you don't get PT. That is not an effective way of coordinating that care for that patient. These are some of the skills that you need. And these are some of the skills we're trying to help you develop. Problem solving, planning, ability to use the skills of others. Okay? And that's what we're going to talk about in just a few minutes when we're talking about delegation of care. Identification of needed resources, communication, collaboration, and lastly, evaluation. One of the most critical steps in that nursing process is evaluation of the effectiveness of care. Why? If it's not working, are you going to continue to do the same thing over and over and over again? No. That's the definition of insanity. Doing the same thing again and again and expecting different results. Okay? So what you need to make sure is that you evaluate so that you can sort of do that problem solving. Now, to coordinate care, these are some of the things that you need to have available in your skill set. You need to have what clearly understood goals are. Okay, and that's whenever you establish that nursing diagnosis and develop that goal. That, as the RN, is the goal that all of those team members should be trying to accomplish. And to do that, you need to be able to use effective communication to all team members. This is what we're trying to accomplish with this patient. It's sort of one of the reasons that critical paths or care maps was developed, because it is a written representation of the plan of care for that patient. Everyone that's on the healthcare team can look and see, what am I supposed to be doing on this particular day? What is this patient supposed to be doing on this particular day? Knowing policies and procedures is one of those things that you sort of have to do when you work in a healthcare institution. Or they are covered by insurance or Medicaid or Medicare. You've never seen the rules until you've dealt with Medicaid or Medicare. And we'll talk about that later. Fun, fun, fun. But what you're going to see is that you need to make sure that you accept different expertise required to meet those clients' needs. As the RN, you need to recognize you are not the expert in everything. You may coordinate the care, but you need to recognize there are people that are more skilled at certain things than you might be, that may have more time, i.e. the development of the diabetes education staff at a lot of these hospitals, because they have the time to develop what this patient is going to need to know. And often what you will see is those diabetes educators not only follow them in the hospital, but they see them in the clinics as well. Okay? So, recognizing that expertise. Now, this is another biggie, guys. When you're talking about delegation, it is one of the roles, most important roles that you'll see of the RN. Whenever you're talking about delegation, you're talking about transference of responsibility. You're talking about transference of authority to a competent individual. Three components: responsibility, authority, competent individual. One of the things that you need to remember is that in order for them to accept that delegation, the delegee or delegate has to assume responsibility for the completion of whatever task was delegated. Now, the delegate or the person that assigns the task, even though they may not do the physical catheterization, they retain accountability for that action to be done. Okay? So whenever you delegate, you transfer the responsibility and the authority to act to that competent individual. But as the RN, you retain that accountability. It is your job to make sure that that task that you've assigned has been completed. Okay? Well, the reason we do delegation is that so that we can devote time to other tasks. The other thing is that we hope that it will increase the skills and the abilities of the delegate, the person that is delegated to. Because you all know, the more you do something, the more practice you have, the better you get at that particular skill. Okay? Now, one of the reasons that we developed the skill of delegation were changes in the healthcare environment. What happened back in World War II, just as an FYI, for all the history buffs in here, is that most of the RNs in the healthcare system were drafted into the Army or either joined voluntarily, so that there was a corps of healthcare providers for the soldiers. Well, what did that leave? It left a very few RNs, but it left a lot of LPNs or practical nurses, and it left a lot of unlicensed assistive personnel. And UAP is a term that you will see both on NCLEX and on my test next Wednesday. UAP. Now, what does that mean? Who are some people that are UAPs? CNAs. Care partners, PN, whatever. And that's one of the reasons why NCLEX calls them UAPs. Alright, CMC Northeast calls them care partners. ROAN calls them CNAs or nursing aid. Okay? You may see also orderlies. You may see surge techs. You may see any group of people. Those surge tech is one of those iffy ones. A lot of them are certified instead of licensed. So what you will see is that anyone that does not sit for a licensing exam, okay, well, you think, well, nursing assistants have to take a test. That is a certification. It is not a license. There's a difference between a certification and a license. Okay, so NCLEX will use UAP, unlicensed assistive personnel. And basically what you need to remember with that is that what can I sort of generalize about who I can do what? Okay? With North Carolina, those of you that have completed your NA2, what additional skills can you do that the NA1 cannot do? Catheterizations, take out IVs, dressing changes, suctioning, trach care, ostomy care, and apply oxygen, and there's one more. Okay? What North Carolina does, I'll just let you know, is that there is a law that allows them to do NA1 plus 4. They can do up to 4 skills on the NA2 list if they've taken those people through special training and have done competency checkoffs for them. Okay, up to 4. But if it goes beyond 4, they have to be certified as an NA2. Alright, so North Carolina has this law, Texas has this law, Oregon has another law when they're just talking about UAPs. So whenever you are approaching a question on NCLEX, we're going to generalize. Don't think, but in North Carolina, put that out of your head. What are you going to see pretty much across the board? And that's what I'm going to talk to you about now. Okay? In order to know how to delegate, what you need to do is to be able to read that Nurse Practice Act. And what are the roles, responsibilities of the RN, the PN, as well as licensed assisted personnel. What you're going to see is that you also need to know the capabilities for each staff member. Would I be more comfortable delegating a skill to someone that has 5 years of experience of doing catheterizations? Yeah. Would I be less comfortable delegating a catheterization to someone that just had done one checkoff? Yeah. Which one am I going to follow a little bit more closely? Okay. Which one should I follow at all? Both of them. Because I still retain the accountability for that action to be done. Okay? You need to know what tasks can be delegated. And there are rules about what can be delegated. And then again, always remember that even though it was delegated, as the RN that's responsible for the coordination of care for that patient, you retain the accountability. Now, there is a difference between delegation and assignment. I delegate to someone that has less skill than me or less license than me. I would delegate to a PN or a UAP. If I'm working with another RN and I'm the charge nurse, I don't delegate that care of that patient, I assign them care. It's a legal term, but RNs to RNs assign. They don't delegate. Okay? RNs delegate to people with less licensing than they do. PNs, UAPs. Now, one of the things that you need to remember is that your RN cannot assign or delegate to an individual an activity that's outside their job description or scope of practice. For example, if you have someone that has to have traction set up, typically what you're going to find is that most hospitals will have an orthopedic tech that comes and sets up the traction, so that we make sure all the things are tightened appropriately and that it's not going to fall down on the patient's head. And the overbed frame doesn't fall down on the head. In the hospital that has that orthopedic tech, that's their duty, typically RNs do not do that function. So it's outside of my job description, right? So if the orthopedic tech is not available, can I tell the UAP to set up the traction? No. Because it's outside of my job description. Now, what would be something that would be outside of my scope of practice? Tell someone to write me an order for even colace. Okay? If it is not covered by these standing orders, that's outside your scope of practice. And that's one of the things you need to be very careful about, is reading what is in your scope of practice, what is not. And one of the things that the Board of Nursing will do is they typically will what they call position statements. Okay? And there is a position statement that says from the Board of Nursing that point of care blood glucose testing is not really a nursing duty. Meaning that it doesn't take a nurse to do point of care blood testing. It's not outside of the realm of the UAP to do so. But what you're going to see is that each hospital will have their particular policy and procedure that will govern who does that. Okay? Position statements are one of those things that sometimes they waffle a little bit. And what they'll say is that it's maybe within or not in conflict with the practice as an RN. So what you'll find is that when there is a new position statement, as a licensed RN, you will get notification of that. And I would behoove you to read those carefully, because it will govern what your practice is in the state of North Carolina, or the state of South Carolina, or the state of Texas, wherever you may be.
So it's maybe not like per state.
It's per state. Each state has their own Nurse Practice Act. A lot of times hospitals will change their policy based on that. The thing is that with hospital policies and procedures, they can be more restrictive than the Nurse Practice Act, but they cannot be looser. Okay? In other words, they cannot ask you to do something that's in violation of the Nurse Practice Act. All right. So, one of the things that you will see about delegation, and I'll tell you as a new RN, it's very hard sometimes to give up that control, because a lot of times what you think is, I can do it better. Well, I know I have to retain the authority and make sure that the responsibility and the authority to make sure it's been done. So if I do it myself, then I know that it's been done correctly. Or I'm unsure of who is allowed to do it. One of the reasons that you're not sure who's allowed to do it is that you haven't prepared yourself by reading what those practice acts are and the hospital rules and procedures. I call this the little red hen syndrome. Okay? You know, like the little red hen said, let's go gather some seeds. And no one wanted to do it, so she said, well, I'll just do it myself. Well, what happens is that the little red hen does everything herself and is exhausted at the end of the day and can't eat the bread that she made. Okay? So, unfortunately, it's a hard skill to master, but it's one that you're going to have to. And you want to come off with doing it not being bossy. Because I know some people have bossy pants. And they certainly can come off very bossy, but you're going to have to learn how to do this skill so that you can survive. Because there's a lot of stuff you have to do, and if you try to do everything yourself, you're not going to be able to do it. These are some of those UAPs that we talked about. These are the main principles. You can delegate only those tasks for which you are responsible. along with the responsibility, you must transfer the authority to be able to do that act. Responsibility is transferred and the accountability is shared. That UAP is responsible for getting the task done. You are responsible to make sure that it's been done correctly or what the results are. Well, know well the task to be delegated. If I've never changed an ostomy dressing, can I delegate that to my UAP? Because I don't know what I'm doing. I don't know if she did it correctly or not. So you need to know what the tasks is. Now, what if I know what I'm doing with an ostomy dressing, but that UAP does not? You need to show them. Okay? One of the things that you're wanting to do is to make sure that not only you develop your skills as a delegator, but that unlicensed person that's working with you, not for you, but with you, develops their skills as well. Delegation is a contractual agreement that is entered into voluntarily. Well, sometimes voluntarily is by job description. Okay? That means if you delegate a task, you have to have some assurance that that person heard you delegate that task and that they accepted that responsibility for doing so. Okay? One of the things that I want you to remember is this is what you don't delegate. You do not delegate what you can eat. And I've got this big piece of fried chicken here to help you remember. EAT stands for evaluate, assess, and teach. These are the responsibilities and the job duties of the RN that cannot be delegated. The evaluation of care. The evaluation of the therapeutic response to medication or side effects. You cannot delegate the initial assessment or assessment after procedures. Now, once the RN has assessed, that licensed practical nurse can do what they call observations. It's an assessment, but their scope of practice is limited in that it cannot be the initial assessment. It cannot be the immediate response. Their observations are done on stable patients that do not have rapid changes. You do not delegate what you need to teach. You as the RN need to assess and evaluate where that patient's knowledge base is and develop that teaching plan. Now, does that mean that once I've developed that teaching plan as the RN, that the LPN can't come in and show them or reinforce that teaching? No, it doesn't. They can reinforce teaching. In fact, most of the time what you're going to see is that is one of their major roles in teaching is reinforcement of that plan. But they cannot develop the initial plan. It has to be developed by the RN for them to follow. Which is one of the reasons that we take you through that nursing process with the nursing diagnosis and development of that goal and that interventions. Okay, that's your plan of care for your practical nurse to follow. That's their prescription for care. That's what helps guide the care for those patients. Now, one of the things that I gave you in the handouts. There were like 100 zillion, I know. But there were position statements for RN and LPN practice. There were position statements for delegation of non-nursing functions. And then there are the RN, LPN scope of practice. So if you've got that, let's pull that out and take a look at some of the things that are different. If you look at the RN, LPN scope of practice comparison, these come directly from the Nurse Practice Act. And one of the things you need to remember is that the Nurse Practice Act is a rule of law. It is voted on by the legislature, and it is a general statute in the state of North Carolina. So any time that there is a change in the Nurse Practice Act, it has to go before the legislature and be voted on. Okay, it is law, guys. Just like not running a red light. The registered nurse, as I said, assesses, determines the assessment, collects, verifies, and interprets the data in relationship to health, and then formulates the nursing diagnosis. If you look at the LPN scope of practice, it is dependent on the availability of RN supervision and practice setting variables. With assessment phase of the nursing diagnosis, they collect data, they recognize relationships to that diagnosis, and determine immediate need for intervention. And that need for immediate intervention may be a nursing act, or it may be notification of the RN, depending on what the situation might be. With the planning phase of the nursing diagnosis, you will see that the RN identifies client needs, determines priorities of nursing diagnoses, nursing care goals and interventions as appropriate, and they develop that plan of care. Your PN participates in identifying the client's needs through suggestions of goals and interventions. Do they develop a plan of care? No. Implementation. The RN implements that plan of care, including procuring resources, assignment, delegation, and supervision of licensed and unlicensed personnel. So the RN supervises the PN as well as your UAPs. You look at PN scope of practice, you will see that implementation of care is with the following limitations. RN supervision is required. Well, you're wondering, well, how did the nursing homes get away with that? Well, the RN usually is easily available by phone, or there may be one RN somewhere in the facility. Okay? Basically, PNs can give others assignments to other LPNs, and they can delegate to UAPs. Who can the poor UAP delegate to? Nobody. UAPs cannot delegate, period. They cannot delegate to students. They cannot delegate to other UAPs. Supervision by the LPN is limited to assuring that tasks have been completed according to agency policies and procedures. Okay? With evaluation, the RN evaluates effectiveness of nursing interventions and achievement of patient outcomes, and then modifies the plan of care. The PN, although they participate in the evaluation, by identifying the client's responses, they suggest revision. They cannot do any revision. That has to come from the RN. If you look at reporting and reporting, both do that. However, typically what you're going to see is your PN is going to report to your RN. Your RN reports to the other members of the healthcare team. Physicians, nurse practitioner, physician assistants, and other providers of care. With teaching and counseling, the RN is responsible to teach and counsel clients, families, and groups, identifies learning needs, develops and evaluates teaching plans, and makes referrals if appropriate. The PN participates in the teaching and counseling, usually the reinforcement of that teaching plan that's developed by the RN. With managing nursing care, the RN is responsible for that management of care. They supervise, they teach, and evaluate nursing personnel. Look at the change in color on this chart. It says it is not within the LPN scope of practice to manage nursing care. Limited supervisory roles for PNs is noted in the implementation category above. In other words, a PN cannot be in charge of a nursing unit. In long-term care facilities, what you may see is a PN that is doing team leading on that unit, but there is an identified RN that's in charge. Okay? And that is one of the things that a lot of people get into trouble with long-term care facilities if they don't have an RN that is supervising that PN staff. Okay? Administering nursing services. Basically, that means like a charge nurse or nurse manager or nursing supervisor. That is within the scope of RN practice, but it is not in the scope of practice as an LPN. And then again, accepting responsibility for self. As licensed personnel, they are responsible for following the rules and regulations set forth in the nursing scope of practice. Okay? So what you're going to see is this is something that you need to know. What's in the scope of practice for RNs, LPNs, and then what about CNAs? Well, like I said, this is North Carolina. What you're going to see is that's mostly going to be personal care for ADLs, positioning, ambulation, feeding, enemas, maybe, infection control, CPR, vital signs, as assigned by the licensed nurse. And that can be either an RN or an LPN. All right, PNs can delegate to UAPs. PNs can delegate to UAPs. They can assign to another PN. Can they ever assign to an RN? No. I don't care how green you are. It's not within their scope of practice. In North Carolina, as I said, CNA2, sterile dressing, discharge DC peripheral IV sites, G-tube feedings with an established G-tube, and this is the key, established G-tube that the RN has checked position on. You can't just say, here, take this can and go feed them. You have to check location of that tube and make sure that it's accurate. Suctioning, and they can do catheterizations. Now, yeah, they can do catheterizations, but am I going to let them catheterize this 98-year-old guy with BPH?
No.
Why not? Is that a stable patient that you are not anticipating complications on?
Mm-hmm.
Well, he may be stable, but you start going to poke a catheter up near his prostate, and then complications are probably going to ensue. Okay? So, even though they're okay to do these things, think about what your patient condition is. Again, what is their skill set? Again, these are some of the things that can or cannot be delegated to UAP. Now, talking about peripheral IV lines. What about PICCs? Is PICC a central line, right? Okay. They cannot take the PICC out or do anything to the PICC. They cannot do insertion of NG tubes. However, they can, if the NG tube placement has been confirmed, they can give a feeding through that NG tube. But it's up to the RN or the PN to get the RN to confirm placement. Okay? Remember, confirming a placement of an NG tube, is that an observation or is that an assessment? Okay, we do not delegate what we eat. Evaluate, assess, or teach. Okay? Always, always, always assess first. You have to assess before you can delegate to that UAP. The other thing is that that patient has to be medically stable or chronic, or this is a chronic condition. All right, say for example I have a post-operative patient that I've got physician orders for vital signs Q15 times 2 hours, Q30 times 2 hours, Q4 times 8 hours, and vital signs routine after that. All right. First vital signs is come back. My pulse is 136. Blood pressure is 90/60. Okay. Does my UAP get the second set of vital signs? No. Okay. That patient is not stable enough for them to get those vital signs. What about, same situation, post-operative patient, blood pressure is 145/88, pulse rate is 102. I'm okay with that.
Yeah.
Okay? 102, they may have a little pain. They may have a little bit of being anxious from just waking up from the anesthesia. 145/88, it's a little high, but most people walk around with that. Okay? So I would be okay with letting my UAP take the second set of vital signs. However, what am I going to make sure that they do? Do they just document them on the chart? No, they report them back to me. And that is something you need to make clear. If I tell my UAP, I need vital signs Q15 times 2 hours, report back to me with what they are. make sure that you give them full instructions. Task has to be considered routine for this client. Not require substantial scientific knowledge or technical skill. It's considered safe for this client, and it has to have a predictable outcome. In other words, if I have someone that is getting ready to go home for discharge, and they have a peripheral IV, do I delegate that to my CNA that has that +1 skill, or is a CNA 2? Okay, but what if their INR is 4.5? Okay, it makes a difference. It has to have a predictable outcome. The majority of time, what you're going to see is that you take that IV out, you hold pressure on it for a minute or two, and then you put a Band-Aid on it and they're good to go. Okay? Versus someone with that high INR that you don't know how long it's going to bleed. That is not a predictable outcome. Other things you have to know is, what are your agency's policies? For example, I know that at Rowan, I've seen the NAs walk around with the +3 or the +2s or whatever. Okay, well, which of those two are they checked off on? You have to know. And what's the best way to find out? Yeah, ask them. But do I take them at their word? Okay, the motto here is trust but verify. Trust but verify. If you're unsure of their abilities, then you want to observe them. At least do one. And if they get that well and good, then you probably are going to be okay. But again, you have them report back to you with what the results were. You want to create a positive atmosphere, okay? It's easier to get flies with honey than it is with vinegar. Alright, if I say, Aaron, you need to go do a catheterization. What kind of response am I going to get? Like, well, okay. Just like at the McDonald's this morning, it was wild. I had to get out of line and go in. This lady got out of the car and bitch slapped this guy in the truck. And I thought, I'm out of here. Because he jumped in front of her in line. She got out and spanked the car out of him. So, I'm sure police ensued, but is that McDonald's over near your house? But anyway, tough crowd over there. But I would much rather approach it like, I need you to go, I need a catheterization done on Mr. So-and-so. Would you let me know how much you get? He has not voided in 8 hours, and I'm getting concerned, so I need to have it done within the next 30 minutes or so. You give them a time frame, just like you would an order. You give them something to follow up. I need you to let me know how much you got now. Okay, so that you want to make sure that they understand the task that you've delegated to them. Now, as the delegate-E, what I would do is say, okay, I will catheterize Mr. So-and-so now, or I'll do it in the next 15 minutes, and I'll come back to you and let you know. That way is clear communication that you know that they've heard what you said and they know what the time frame is. All right. It makes a difference if you say, Mr. So-and-so has voided, I need him to be Kath. When would they do it? Whenever. Well, I'll do it when I get back from lunch. No, I need you to do it. They delegate it to the next shift.
Yeah, really.
RNs would do that too, but that's not.
Question, and this might have been a reason when I was talking about it. So I know that like I can get accountable for that task to be done. Okay, I've delegated that to you. I'm accountable for you to get that task done. Okay, what if like an injury occurs, like something back on me?
Okay, that's a very, very good question. Okay. Her question was, is I delegate a task, and if an injury occurs while the other person is doing that task, does that come back on my nursing license?
Yeah.
Only if you did not adequately supervise. Okay? If that person had had the necessary education, or they had been competently done a competency check off, then basically if you supervised their task, then it's not on your license. But the problem that you get into is with inadequate supervision. Okay, making sure always that you follow up. Because remember, you retain that accountability. And you're only accountable if you did not adequately supervise or follow those principles of delegation. Okay? Now, if it is another RN or an LPN, you either assigned a task to an RN or you delegated to that PN. They are licensed personnel. So they are responsible, they have the authority, they have the accountability for that task. But if you delegate that to a PN, again, your responsibility is to make sure that they're adequately supervised. It's sort of a shared responsibility, and if you did not supervise them, then yes, you're legally liable.
So basically saying if I delegate something to somebody, not really knowing if they can do it or not,
that's inadequate supervision. Why do you think that we follow you around like hawks in clinical? We ask you all of these questions. That's why we are so careful with this, because we're making sure that you have adequate supervision. Okay? Now, a couple of other things you need to want to communicate. The task that's to be done, when the task is done, and what the expected outcome is. Who is available as a resource? If you have questions or have problems, I'll be in room so-and-so. Come and get me. When and what format? Come back to me and tell me how much you got. Or just put it in the chart. I'll look it up. But what happens if you tell them to put it in the chart and I look it up and then you forget? Is that adequate supervision? Okay? Again, it's that evaluation that you have to do. UAP never delegates. Except maybe to the dog. All right, 4 C's of initial direction. Is it concise? Is it clear? Is it complete? Is it correct? Those are the things you have to realize whenever you're doing delegation. Is what I'm saying understood? That's one of the things whenever you delegate a specific task, you want that person to come back to you and say, I will Kath Mr. So-and-so in 15 minutes. It's going to be an in and out Kath just to see how much he's got in his bladder. Is it concise? Have I confused the direction by giving too much necessary information? No, I'm not listening. Think of some colorful instructions that you may have got last year. Okay? Enough said. Is it correct? Do the directions follow policy, procedure, job description, and the law? That's why you have to be very, very careful about making sure you read those things. And Lord only knows, policies and procedures are not fun to read. But I'm going to tell you, they're going to CYA. If you follow the policy, if you step outside of the policy, then you're going to be in trouble. Is it complete? Does it give all the information necessary to complete the task? Well, think of something that may have to be done with a special piece of equipment, like a bladder scanner. Not every unit in the hospital has a bladder scanner. You pull someone from one floor that has their own bladder scanner, and they don't know where the bladder scanner is located on your floor. I need you to bladder scan Mr. So-and-so, because I think he's retaining urine. Well, what is that UAP supposed to do? Go to their floor and get their bladder scanner? They may have to, because it may be the only one in the hospital. But you need to let them know if there is special equipment that needs to be done, where is it? And what are you going to allow them to do? I understand you have to go to the unit 2 doors down to get this bladder scanner. So I'll cover your patients while you're gone. Okay? But the 4 C's: clear, concise, correct, and complete. Making sure that you've covered all of that information. Now, there's a difference between delegation and assignment. Delegation transfers responsibility and authority. Assignment is there's no transfer of authority. Think of it this way. An assignment would be done RN to RN. They're both licensed people, and they're responsible for that coordination of care. So there is no transfer of authority. Assignments reflect job description and client needs, as well as organizational needs. Mostly think of RN to RN as assignment, PN to PN as assignment. UAP can't assign or delegate. So, but think of this mostly as determining who's going to get what patients per shift. That's an assignment. Now, there's a difference between delegating and dumping. You delegate because it's the best use of your time and what's going to be greatest benefit to the client. It also provides those delegates with opportunities for growth and increasing skills. I love this little cartoon. It says, I start my day of making a list of everything I need to do, and then who I can get it to do for me. All right, is that delegation or is that dumping? That's dumping. Now, this is Ms. Hyde's soapbox. One of the things that absolutely drives me crazy, yes, I am an RN, and yes, I know my time is valuable, But if it takes me 15 minutes to track down a UAP to put something on the bedpan, then I could have had that done and complete from the time that I walked in that door.
Or if you're in the room.
Or if I'm in the room.
And come out and say, I need to get it's different if you're
I work in a nursing home, we have bed alarm. And there's a bed alarm going off in the room, and the nurse is standing outside of the room with her bed alarm and wanting to stay in bed.
See, that drives me crazy. I mean, one of the things that you've got to remember is that, yeah, my time is valuable. But what am I doing to that patient's safety if I'm leaving them, or their needs, definitely, if I leave them without at least addressing that basic need? Please, 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 you know, it is a health care team, okay? Just because we have the authority by law to delegate responsibilities and roles, that does not mean that we're above putting someone on the bedpan or walking someone to the bathroom, okay? However, what I would tell you is that sometimes it may be that you walk them to the bathroom and then you call and say, I need help in here because I've got to continue my med pass. So, that's my soapbox for today. So, what I would tell you is that is one of the things that will get you the more cooperation with your UAPs and your other members of your healthcare team. If I have to walk around 15 or 20 minutes to try to find something, that patient's going to be up and on the floor. And then where am I? Filling out an incident report because they got up and fell. Okay? Just be aware that delegation does not mean dumping everything else on everybody. Okay? All right. Let's take a break. Be back. Those therapies your test next week. Okay, so make sure that you have read through those. Most of the things that are in here have been supported by what I've said in class, but just be aware they're fair game. Delegation, whether the nurse's responsibilities, and the board of nurses called. Okay, they're both posted. What I've got up here now is the position statements from the North Carolina Board of Nursing. One of the things that you will see is that as you read that Nurse Practice Act with the rules, lots of times what you'll find is it's law, so it's legalese. And so what they've done is they've come up with these position statements in order to translate into real people language. Something other than what the lawyers and legislators do. Okay? So basically what you're going to see is that there will be a position statement. If there is a question about practice as a nurse, typically what the Board of Nursing does is they do an evidence-based research, evidence-based practice research, and they look to see what the National Council of State Boards of Nursing. It's sort of the governing umbrella of each of the individual states' boards of nursing. So what you're going to see is they will eventually come up with what we call a position statement. And it basically, when you look or have questions about your practice as an RN or LPNs or UAPs, then what I would do is go to this nursing practice position statements and decision tree site, because this is probably the most easily readable without a law degree. decide to finish your RN and go get your JD, there's megabugs out there in malpractice. So, what we're going to see is I pulled up this so that I can show you that decision tree for delegation to the UAP. What you're going to see, if I get it big enough so you can see it, is one of the handouts. Okay, as I said before, is the task within the scope of practice for a licensed nurse, either an RN or LPN? If the answer is no, then you don't delegate it. Because remember, what you delegate has to be within your scope of practice. Well, if it is that activity allowed by the Nurse Practice Act, board rules, statements, or any other law, rule, or policy? No. Well, then you don't delegate it. But if it is that RN assessment of the client's nursing care needs complete? Remember, the RN has to assess prior to delegating anything. Complete your assessment and then proceed with consideration of delegation. If it's within that scope of practice, are you competent to make those delegation decisions? Remember, the nurse is accountable for the decision to delegate, to implement the steps of the delegation process, to assure that the delegated task is appropriate based on the individualized needs of each client. Okay? Back to my catheterization example. Just because they have had the education and they've had the competency checkoff doesn't mean that they're competent to catheterize everybody. If you've got a woman that has a uterine prolapse down to her knees, that was my first shaving prep for surgery, guys. I was afraid that they were not going to have to do a hysterectomy the next day because I was going to take care of it with my shaving prep. Then that is not an appropriate person to delegate. It probably wasn't appropriate for me to shave and prep that woman. But that was back years when I didn't know anything. So, each patient, you have to assess each patient. If it is not a stable patient, routine care, or if you don't expect the usual outcome, then you do not delegate that procedure. Okay? Properly trained, competent by an RN to delegate. In other words, if I ask a CNA or UAP to do an ostomy dressing, they've never been trained, never done it before, then they need to come back to me and say, I have not done that, I don't have the education to do that. Then I should not delegate that task. However, if they come back to me and say, well, I've seen it done I've had the education, I've done one checkoff, but I don't feel safe doing it, then that is okay to say, let's go and I'll help you. Okay, you can supervise that, but they have to have that educational component before. And it's typically with that one, because it's an NA2 skill, it can't be on-the-job training, okay? Since it's a skill that's identified by the Board of Nursing as an NA2, it has to be formal education. It can't be just, come in this room and I'll show you how to do this. Okay? You know. So, follow this. And you will see that there is a second page to this with the variables. Please make sure you read through these. And if you look at the 5 rights of delegation, is it the right task, the right circumstances, the right person? And that can be either two ways. Either the right person that you're delegating the task to, or the right patient to delegate that task to. right directions and communication, right supervision and evaluation. Okay? These are very valuable tools in order to help you to develop your skills for delegation. Now, priorities. Let's go back to the other. When you're talking about priorities here, this is sort of like the priority setting that we've already talked about. Based on Maslow, basic needs come first. Oxygen. Physiologic needs come first. Basically, you want to delegate appropriately, and the thing that you need to remember is that you want to use your personnel wisely. You do not assign an RN to do non-nursing functions if it can be helped. It is a waste of time and talent. Okay? One of the things that has occurred in my practice, back in the day, they decided that they were not going to have housekeeping staff on evenings, with the exception of the clean team, the person that did the bed cleanings. So garbage wasn't going to be emptied, and you know, if you had problems with spills, the RNs could do it. All right. So what they established was with this routine of the RNs would empty the trash in the rooms. This is back before we had UAPs. The RNs would empty the trash. The RNs would clean the toilet if necessary. The RN would do anything that housekeeping needed to do other than clean the beds for new admissions. And we said, okay. So what we did in order to combat this little money-saving thing that they did with decreasing the housekeeping staff is that we kept timetables. How long did it take me to empty the trash or do whatever a housekeeping task needed to be done? What we found is that doing that at our RN salary, they could have hired 23 people for that evening shift to empty the garbage. So how long do you think that lasted? Okay? Sometimes you just need to suck it up and provide them evidence that this is really not saving money. Alright? Make sure that if you have non-nursing tasks, that they're assigned to non-licensed personnel, as long as it's within the scope of their practice. Now, one of the things that you always want to consider is relationships. Fairness. You want to be fair to the people that you delegate to. You want to be fair to the people that you assign other things to as charge nurse. What's one of the hardest things that you guys have done as team leaders, those that you've done team leading? Make assignments. Why is it hard? Because payback's a bitch, right? Because you want to make sure that you are fair to your fellow students, but you want to make sure that they have that learning opportunity. Okay? And unfortunately, sometimes staying in our nice little comfort zone doesn't provide us that opportunity for learning. Compatibility. What do I mean by that? Yeah, look at their skills and their personality and their ability to do whatever you need them to do. You know, there are a lot of people out there that you just don't like and you prefer not to work with. But I'm going to tell you guys, unfortunately, what happens is that someday, even though you can avoid the majority of the time, someday it's going to be push come to shove. And you're going to have to deal with it. So what you want to do is deal with it in a fair way. But got to remember what your responsibility is as an RN. Now, staff preferences. What do I mean by that? Either a male wanting a patient preferences or even your UAPs. I mean, some UAPs would rather not work with cancer patients because their mom is actively dying with cancer. So you have to consider some of that. Staff preferences, it may be that someone is really good at catheterizations. It's just like some RNs are really, really good at starting IVs. I'd much rather have them to start my IV than me poke that patient 2 or 3 times and not be able to get it and then have to call. Hopefully what you're going to see is that if you delegate, you're going to have more time for complex client care. And unfortunately, what's happening with the healthcare system right now is that the RN has become a little bit removed from the bedside. Yeah, we do assessments. Yeah, we do some treatments. But what is the majority of our work right now? Charting and documentation. Okay? And one of the things that a lot of hospitals are starting to do is move that computer into the patient's room so that you will be in that room while you're doing your documentation. Number one, it provides immediacy. You're able to immediately document whenever you're doing that care. Number two, it keeps you in that patient's room. One of the things that I tell my students, if I am giving IV push medication, if I'm going to take more than 2 minutes to give that medication, say it has to go over 5 minutes, what I want that student to do is to pull up a chair, sit down on eye level with that patient, and you talk to them while you're doing that medication. Why? It's the relationship. Whether you actually care more or not, the patient perceives that you do. Because my nurse sat down and talked to me. And it also may be the only time you get to sit all day long. Okay? But think about things like that. If you've got to push a med that takes 5 minutes or longer, sit down, talk to that patient while you're doing it. As long as you can remember which syringe that you're pushing and don't get confused. But the perception is there that you care more for that patient than if you just did it. Okay? The other thing is I'm going to caution you is that make sure you're not talking over the patient. If there's more than one healthcare person in the room, the UAP and you, make sure you involve that patient in the care, because they're the one that needs to be taught, this is why we're doing this is what we expect. What are your concerns about what we're doing? Okay? They could care less that you went out last night. Involve that patient in that conversation. What are some of the benefits to the manager of delegation? The manager being head nurse. As a new nurse, if I don't delegate anything, am I going to complete all my care on time? Why not? If I have little red hen syndrome, then I'll do it all myself. Are you going to be out of there on time? No. You're going to be stuck late doing documentation or whatever, completing your work. Other things that you'll see is that it cuts down on overtime. It basically will increase not only patient satisfaction, but it will increase worker satisfaction. It also allows your unlicensed personnel to gain those new skills and become more competent caregivers on the floor. Remember here, you delegate what you have responsibility for. It has to be within your scope of practice. It has to be routine. It should be whenever a task that the nurse does not have time to do physically, and you want to delegate the lower priority tasks. Define the task and decide on the delegate. Well, unfortunately, what you're usually going to see in the hospital is that you may have one UAP for the whole floor. That's becoming more and more the case. So do you have a choice in who you delegate to? No. Or if there are two UAPs, then often what you'll see is that you have rooms 1 through 15, you have rooms 15 through 30. So sometimes your choice is a little limited there as well. Describe that task. Remember, making sure those 4 C's: clear, correct, concise. What's the other C? Complete. Making sure that all of those C's are covered. And then you want that delegee, person to whom you delegated, to say, okay, I will do so-and-so within this time frame. And I will report back to you when I'm done. Monitor that performance and provide feedback. Thank you goes a long way. And a sincere thank you goes even longer. I really appreciate what you did. It saved me a lot of time. Alright, we talked about all of these. Grumpy Cat says, I do all the things. I am tired. You know, Grumpy Cat is coming out with Christmas calendars now. Grumpy Cat has everything. Obstacles to delegation and non-supportive environment. Well, if you don't have the ability to delegate because there's only one CNA and they're trying as hard as they can to do everything for everybody, that's pretty unsupportive, right? That delegator, the RN that's trying to delegate, is very insecure. What message does it give if I say, Shannon, I need you to go cath Mr. So-and-so, while Shannon's working on something else? And then she gets all of her equipment together to cath this patient, and then she goes to the room and you say, oh, I've already done that. What message does that give to her?
Trust her. She's confident.
That I don't trust her, I don't think she's competent. I mean, one time I'll give you a little leeway, but after you do that to me 2 or 3 times, I'm going to start questioning whether you think I can do my job. Okay? You give them the responsibility, you have to give them the authority to do that. Now, when do you take it back? If they are doing it incorrectly or not within that time frame that you asked them to do. But would it be better if they didn't do it within the time frame, instead of doing it yourself, unless it was an emergency situation, to say, have you been able to have Mr. So-and-so yet? No, but I'm going right now. Sometimes clarifying expectations are really key as well. An unwilling delegate. Do I even have to say it? How many people have you seen in your practice as a nursing student that have been unwilling to be delegated to? Well, some of that is because of your role as a student. Because you're not there yet. But often what you're going to see is that some CNAs will, I've been here for 15 years. I know more than that little girl will ever know that just graduated from school. Cut her some slack, because she may be right about some things. The routines of the unit, the routines of what she has done, but remember what her scope of practice is. Alright, it is not within her scope of practice to assess, evaluate, or teach that patient. That's within the practice of the RN. Alright, ineffective delegation. My boss said to change the sign, so I did. What key point of delegation did this boss not cover? It's not clear and precise or concise. I can remember, oh God, this used to be back in the day before America's Funniest Home Videos used to be on. It used to not be videos, it used to be funny pictures before the advent of everyone having a video camera. The Holiday Inn in the Chapel Hill said, the sign said, "Have your next affair with us." And what they meant was like banquets or, weddings or something like that. But I've got this picture of the sign that says, "Have your next affair with us." And I'm thinking, oh my God. Not quite clear on delegation of that sign. Definitely under delegation, remember, some of the times what you will find is that until you get confident in your practice, you will delegate a lot of tasks until you gain some confidence. Remember that some things you just, like the song says, let it go and let them do it. You basically follow up and make sure that it's done. Now, reverse delegation. What do I mean by reverse delegation?
Lower rank. No, somebody in lower rank has
CNA saying, "I didn't have time, I need you to go do it."
Yeah, CNA saying, "I didn't have time." It's like your kids. Clean your room. Unless there are consequences for them not cleaning their room, what usually happens? Mom does it. Okay? That's reverse delegation. Remember, a decision to not act is still a decision. Over delegation. It's like the guy that says, I make a list of everything I have to do, and then I make a list of who I can get to do it. That's called dumping. Make sure that you don't do that. Okay, let's talk about liability and delegation. We've talked a little bit about this. The RN remains legally responsible for activities that are delegated. You're accountable for the appropriateness of the delegated task and its accurate completion. Remember, part of that is supervision, inadequate supervision. The organization for which the RN, LPN, UAP work is liable for their negligence or malpractice when actions are within standard policy and practice. And that's a key. With actions are within standard policy and practice. If you step outside of the policy or procedure, then that negligence or malpractice is on that individual. UAPs cannot supervise other UAPs. UAPs cannot delegate or assign to UAPs or other nursing students. All right, points to consider. Delegation is not new. It's a skill that has to be developed. And you have to be organized to be able to do that delegation. The key is understanding what those client needs are. It's essential to make sure that you delegate appropriately. All right, before we start on collaboration, let's go over just a few more things from the dear old board. Let's talk about delegation and non-nursing. Alright, remember I told you that point of care capillary glucose analysis of phlebotomy is a non-nursing task. These are not what the Board of Nursing considers non-nursing functions. Laboratory things like capillary blood glucose analysis of phlebotomy, EKGs, are considered non-nursing. The use of an AED, pulse ox and transcutaneous CO2 monitors, handing instruments, that's a surge tech procedure. X-ray procedures. FYI, you do not have to be licensed in the state of North Carolina to take X-rays. In other words, the people in your dental office probably went to a one-day workshop to learn how to take X-rays. So whenever they put all of those lead shields on you, make sure that they cover your thyroid too. Okay? They are not licensed radiography. Audiometric screening hearing tests, vital signs are considered a non-nursing function. Setting up of simple durable medical equipment. In other words, when someone comes from the home health agency, they are usually not a nurse or a nursing assistant that come out and do that. Again, tasks that can be delegated to UAPs must meet all of the following criteria. The RN role is to assure that the UAP common repetitive tasks do not require professional judgment. They validate competency. They supervise the UAP. A PN ensures that the RN has validated the competency. PNs cannot validate competency for anyone, even UAPs underneath them. Patient care activities that are done infrequently should not be delegated by the licensed nurse to unlicensed personnel. Now, this is a new one that has occurred in the state of North Carolina that you probably will see in schools and or nursing homes. There is a new policy statement about delegation of medication administration to UAPs, which gives me pause. But if you look at it, what they're talking about is that it permits the delegation of the technical task of medication administration to UAPs by the RN and LPN. The technical task of med administration is defined solely as giving meds to the client via the appropriately ordered route. Medication aids and med tech are considered UAPs, and there's a whole nother education process for that. Basically, what I would tell you to do is, if you're working in an area that uses unlicensed personnel to administer medications, I would definitely read through this. Typically what you're going to see is that this is actually handing them the pill. It's not preparing them. It's the technical task of medication administration to appropriately educate an incompetent UAP according to agency policy via the following routes. And you can see them there. A lot of them are your orals or your patches. These are not permitted. Intravenous, intraosseous, epidural caudal, intraoral, intrathecal, or cranial interventricular. I'm going to tell you, with these guys, I would be very careful about assigning another RN to those procedures, because you need to make sure that you have a very clear policy. Intrathecal or interventricular in most hospitals is only done by a physician. So these you need to, even if you delegate the administration of the medication, you cannot delegate the professional judgment or decision-making responsibility. And that would be basically your 5 rights and ensuring that that patient doesn't have side effects, toxic effects, or the therapeutic response. Okay? So what I would ask you to do is to read through that. I doubt seriously that on NCLEX they will talk about delegating medication to UAPs, because that is not a nationwide thing. The other thing that I want you to recognize is IV medications for PNs. Okay. Majority of states will allow PNs to administer IV antibiotics, but they do. North Carolina does allow IV push, but there are a lot of states that do not. There are 20 that do allow PNs to do IV push. So I doubt seriously that you'll see questions on NCLEX, but I'm going to tell you, if they do, say no. because there are a limited number of states. The majority do not allow PNs to do IV push medications. There are all sorts of things. What I would tell you is the ones that I posted are the ones that I would be most concerned about. Okay? Questions about delegation? All right, let's take another break. Collaboration. Before, but I want to go into it a little bit more in depth, and then we'll talk about leaders and managers and chain of command. Unfortunately, what happens with this management content is that it all gets dumped into this one unit, these two parts, and there's no way to make it fun. I'm sorry. But it's very, very important information because that's what the majority of your NCLEX is going to be based on. So you have to have this stuff in order to apply the other stuff. So let's go ahead and sort of plow through it, and we will make sure that you have all those delegation roles down pat at the end. All right, we've got 2 or more people working on common goal by combining skills, knowledge, and resources. That's what collaboration is. Remember, I told you that one of the major roles of the RN is that manager of care, the coordinator of care. The other major role is collaboration with other members of the healthcare team and the patient. Okay? And that is one of the key things that you don't want to forget. Because if you can do the best planning in the world, but if it's not something that the patient is interested in doing or interested in following through, how effective is your collaboration going to be with the rest of the healthcare team if the patient says, no, I'm not going there. Not doing that. Remember that patient should be one of the first people that you collaborate with to make sure that they follow through and understand what they need to do. The other thing about collaboration is it avoids duplication of effort. Okay? For example, those of you that have worked at joint camp, who is the person that gets those knees and hips up the first time? Physical therapy. Why? To evaluate their mobility and to provide them with what? Necessary teaching on how to take care of themselves, getting up out of the bed, and making sure they had the right assistive devices, right? Okay? So, I'm a nurse on joint camp. Do I go back in and reteach that patient how to get out of bed again? Maybe. I'm hopefully going to reinforce it, and I'm going to reinforce that teaching every time I help that patient get out of bed. Because Lord knows I heard those 3, no more than 90 degrees, no more than, sitting up this way. How many times? Every time I got out of bed. And it got to be sort of like, okay, I know. No more, no. Okay, well, good. So I reinforce that teaching. What if I reinforce the teaching that's been done by the physical therapist and they still don't get it? You have the physical therapist to come back and reteach. I've fulfilled my role. I've assessed and evaluated the effectiveness of that teaching. Okay? And I may not be the most appropriate person to do that teaching. The physical therapist may be. So I've basically worked with someone with that common goal to combine skills, knowledge, and resources. A lot of times, what I'm going to tell you, it's just like everything else in the world. It's not what you know, but who you know. And that works in more than one way. Because if I know what my resources are in that hospital, I'm not delegating to physical therapy the task of teaching them how to get out of bed. I'm collaborating with physical therapy, okay, to make sure that they know that, because I want to use my resources to the fullest ability. Now, these are just some characteristics and beliefs that are basic to collaboration in healthcare. Clients have a right to self-determination. That is the right to choose to participate or to not participate in healthcare decision-making. They have that right. However, what situation have we just seen that sometimes that right is sort of overcome by the legal system? Psych. Okay? In other words, if they had the intent to harm themselves or others, that right is temporarily delayed for at least 72 hours for that hold, right? There was also a case in the legal system just recently over the weekend. And we'll talk a little bit more about that when we talk about ethical dilemmas. The state of Oregon has the legal standing for physician-assisted suicide. And that patient chose to use that as a way because she had terminal brain cancer. They have the right to self-determine participation in or not participating in that, making those decisions. One of the things that I will tell you guys, if you don't have it now, you better get it, is if you do not have healthcare power of attorney designated, please get you one, because you never know what's going to happen. Typically what you're going to find is that your spouse, by the ex post de facto, is considered your health care power of attorney. But if you're legally separated and you don't want them making your health care decisions and you're not divorced, then I suggest you pick someone else, because legally that's who that hospital is going to go to. Is the person that you have been married to but no longer live with and cannot stand. The other thing that it's going to be interesting to see what's going to happen with making healthcare decisions is the new law that allows for same-gender marriages. Typically what you will find in the past is that these people may have been committed partners for 20 years, but they had no legal standing unless they had gone to do designated healthcare power of attorney. Don't know what that's going to what's going to happen with the new change. Something we're going to have to see. I'd still recommend getting healthcare power of attorney for yourself, even if you are married and you currently love your spouse. Still, it makes a little bit of difference with that participation. Any of you that have kids over the age of 21, they need their own as well. Actually, I think it might be 18 here in North Carolina. It's 18. So typically what you would see is that they need to have a designated healthcare power of attorney. Because if they go to college, they're over the age of 18, they're in an accident, legally, unless you have that healthcare power of attorney, that hospital does not have the right or responsibility to talk to you as a parent. So, just a little bug in your ear. Basically, what you want is collaboration, is equality among human beings in collaborative healthcare relationships. Clients and healthcare professionals receive an equal hearing. 50% of that decision should be that client. 50% should be the healthcare team. What's best is the healthcare team presents options, and then that client is allowed to make their decision from that. This is a biggie, guys. Responsibility for the client's health falls on the client rather than on the healthcare professional. Responsibility for the client's health falls on the client rather than the healthcare professionals. I know of several practices that will fire you as a patient if you do not follow recommended medical advice or you continue to break your appointments. Basically, they say you have 30, they will send you a letter. You have 30 days to find another physician for us to transfer your records because we will no longer see you in your practice. Each individual's concept of health is important and legitimate for that individual. Although they lack expert knowledge, they have their own ideas about health and illness. And one of the things that you will see is that as we move through our lifetime, those ideas for health and illness may change substantially based on what we've been dealt with illnesses and or situations. And I know that a lot of you probably have dealt with clients that have heart failure. And I know Ms. Rummel went over that in class. So what you're going to see is that their idea of what is health is going to change based on what that person can do in those particular situations. Collaboration involves negotiating and seeking consensus rather than questioning and ordering. And what do I mean by consensus? What is consensus? Everyone agrees, kind of. Everyone has input. Everyone has a say. They may not agree totally, but they can live with the decision. Okay, that's what consensus is. It's not a vote. It's not the majority carries. Consensus is the group comes to a decision that everyone can live with, but it may not have been the individual's personal choice. Okay? These are some of the things that you'll see that the nurse as a collaborator is intrinsic nursing. The American Nurses Association has listed some things in their scope and standards of practice. And that's going to include, again, collaboration with clients, families, and other members of the healthcare team. And I'm not going to read these to you, but I would tell you that they sort of go along with what we also said previously. We're partners. We communicate. We collaborate with that plan, making sure that that patient is an active partner in their care. just some more. A couple of other things that you will see is that collaboration with legislators. We offer expert opinions on legislative initiatives related to healthcare. We collaborate with other healthcare providers and consumers on healthcare legislations to best serve the needs of the public. Not only do we do this on a local scale, but exercising that right to vote would help it on a national scale as well as hopefully on a global scale. What we hope to achieve with collaboration is high quality patient care and client satisfaction. And I'm going to tell you, there are going to be some people you're not going to satisfy no matter what you do. The Lord that came back and walked on water could not satisfy some people. But what we want is to try to do the best that we can with what we've got. Collaboration hopefully decreases redundancy, increases efficiency, and reduces emissions. So that if PT, OT, respiratory therapy, nursing, the physicians, and the patient all work together, that needs of that client are met. Okay? That means that we have to have really good communication skills. Typically what would happen in the old days is physical therapy would write in the chart. And then talk to the nurse about saying, make sure the doctor sees my note. Well, in some hospitals, what you would see is that the doctors all wrote their notes here. Physical therapy all wrote their notes here. Nurses always wrote their notes here. And no one read the other people's notes. What a lot of hospitals have gone to now is a interdisciplinary plan of care, so that all the documentation is in one place, so that you can easily read what the other members of the healthcare team wrote. Which do you think provides for clearer communication? The interdisciplinary or everyone having their little place? Interdisciplinary. Because we have to be able to see what's happening with physical therapy to know, well, they've been taught this. If I go in and find that they're still not getting up out of bed right, I reinforce physical therapy's teaching a couple of times and they still don't get it, then I can document that and physical therapy can pick up on it and reteach. What is parallel communication or parallel functioning?
Side by side. Side by side.
Not necessarily.
Communicates with the client.
Yeah, everyone sort of does their own thing and they don't go through a central thing. It's like parallel play. You know, with your growth and development, what do two kids that parallel play do? They're side by side, but they're doing totally different things. Okay? And that's what you see sometimes with healthcare teams. Everybody does their own little thing. But no one looks to see, unless they're that 3-year-old, that I like that toy better than I like mine, so I'm going to grab yours. Okay? Parallel is not one of the best things that you can do. Information exchange and coordination consultation are better than parallel communication, parallel functioning. Co-management and referral means that everyone in that healthcare team plays a part in making sure that that patient has been adequately cared for and their needs are met, and they're able to care for themselves whenever they go home. And who do you think is going to be the center hub?
Client.
The client and the nurse. Okay? Because every time I do an assessment or evaluation of what that patient is doing, then I might have to refer to someone else, to one of those spokes on that bicycle wheel. Okay? So that patient in that RN should be your center hub. When you're looking at the continuum of collaboration, the lowest level is going to be parallel communication. Everyone does their own little thing and no one talks. Versus going up on the continuum where referral. Everyone is used to the best of their abilities and what they were trained to do. Okay? Some of your basic competencies, just get the slide, yes. Some of your benefits, again, it's client-centered care, client-directed. What do you think would happen with overall costs? Why would they decrease? Someone is not duplicating what someone else needs to do. And that's one of the things that you will find on your critical pathways or your care maps, is that everyone's role, everyone's job is delineated on that care map. So that people know that, oh, on today, first day post-op, the physical therapy department gets this patient up out of bed. If that doesn't happen, it's the RN's role to make sure that physical therapy has gotten that consult to make sure. Okay? What do you think would happen with relationships? Why do you think they improve? More trust and respect for the role that other people have in their educational and their resources as part of their resources. What do you think happens for the relationship with the client? Why do you think it's better? Hopefully they'll be more satisfied. The other thing is that how many patients have ever told you that, well, I answered these questions in the emergency room, and I answered them here, and then I answered them somewhere else. Don't you people ever talk? Yeah, we do, but we still have to fill in their form. Okay? A lot of times what you will see is that it improves patient satisfaction because it takes out some of the duplication of that information. Sometimes what you'll see is that, yeah, you might see there's an allergy to a particular medication, but there's no documentation of what that specific allergy might be and what situations did they take that medication from. Remember, allergy doesn't mean it upsets your stomach. But that's what a lot of people will tell you, that I don't take Viaxin because it gives me diarrhea. Well, sorry, but that's one of the side effects. What do you think it does to the work environment?
Decreases stress.
It decreases stress because you know that certain people are responsible for certain things, and hopefully if everyone is doing their job, you should not have to follow up and make sure that things go the way they're supposed to for that patient. It's very supportive. And it acknowledges the contribution that everyone on the healthcare team is going to make. We talked about some of these things communication skills, mutual trust and respect, giving and receiving feedback. And what do I mean by feedback? Thank you is a good one. Okay, corrective criticism. Okay, what situations do you do that? What if you are observing a UAP doing a catheterization and they break sterile technique?
Every time.
Do you yell, no? What do you do? I would just basically put my hand on their arm and say, let me get you another kit. Okay? There are ways to do it without scaring the patient and embarrassing your UAP to death. Be tactful about it. Typically, if you're going to give constructive criticism, feedback to someone, you want to do it in private. You don't want to do it in front of other people, especially not in front of that patient. Because what have you just done if you have done that in front of the patient? They're questioning all of the care that UAP now is giving, where they may be doing a good job on the other things, but they just broke sterile technique in that one situation. And it doesn't help that relationship between you and the person that you delegated either. Okay? Decision making. What are the priorities? What are the have to do's? What are the must do's? What are the nice to do's? You need to set what those priorities are. Because remember, these patients are going to only be in the hospital for a short period of time. What we hope that's going to happen is that case manager is going to collaborate with other caregivers on the outside to provide them the needed care that they're going to need to continue to get better. Because not everybody gets better with 3 days in the hospital. In fact, it's rare that you're completely well when you go home. Because what we're seeing now is patients that are sicker and much more critical. And we're having to deal with care for those folks in a less amount of time, and we've got to ensure that follow-up. It is one of the Healthy People 2020 goals that we increase collaboration. It's one of the leading set of health indicators that reflect the major health concerns in the United States. What can we do with the limited amount of resources that we've got available in our society? Collaboration is essential to nursing practice, and failure to collaborate has really very grave consequences for all of our clients. It may make the difference between a successful hospitalization for that client and that they get better, or failure, so that these people either suffer long-term morbidity or mortality. Okay? Work with other people. Use them to the best of their abilities. All right, let's talk a little bit about management theory, and then we'll be done. All nurses are managers of practice, though not all nurses are not leaders or formal managers. Okay? One of the things you need to remember is that managers are often appointed by your organization. They have the job title that goes along with that. Leaders can be formal or informal. They can be appointed by the organization as well, but they can be informal. Someone that's been on the unit for 20 years that everyone respects and looks up to. Someone that's always saying, all right, let's do this. And everyone follows along because they respect that person's opinion. Sometimes management is sort of like herding cats. That was one of my favorite Super Bowl commercials of all times, where they were herding the cats with the horses. When you're talking about management, you're talking about planning, organizing, directing, and controlling. Those are the 4 key points of management. Planning. Bad planning is buying a new saddle for an old horse. Are your plans appropriate? Have they been organized in a way that is going to allow you to direct the workflow? And that controlling, think of that as your supervision, your evaluation, making sure that people are following through. Some of the other things that you will see is that we want planning to be proactive, not reactive. Okay, what's the difference between those two? Proactive means that I do what?
You anticipate something.
Anticipate. Alright? That's when you see 3 snowflakes, what does everyone in the South do? Red milk.
Red milk.
In Kansas City, it was beer and chips. Because we all knew that the grocery stores would be open the next day. And we didn't have to worry about that. What is proactive planning? That's making sure that you anticipate all contingencies. And that you have a plan A, a plan B. One of the things that I loved about the sign that one of the mental health nurse practitioners had above her desk is that if plan A does not work, remember there are 25 other letters in the alphabet. Okay? So it's proactive planning is coming up with a solution or a possible solution for all contingencies. Reactive planning is what? Waiting till there's 6 inches of snow on the ground and you know that there's nothing in the house to eat. Except the cat food. And you're not too sure about that because the cat won't even eat it. There's You ever seen these things before? Authority, accountability, and responsibility. Okay. Principles of delegation. Principles of management we've talked about. We are going to talk more about time management and managing conflict in this next section, so I'm going to hold off on those. But basically what we want is collaboration instead of a combative relationship. You know, it works if you work together with people, it works a whole lot better than if you work against. What you hope to see is that conducive work environment. Now, chain of command, and I'll finish it up. Basically, this is just one of those principles of management. There are 2 types of authority, line and staff. Line authority usually means there is a direct relationship of control. Staff is an advisory relationship. that purpose of the chain of command, it provides structure. It is one of those things that you know who I should go to report different things. In your chain of command, your first link is always going to be your instructor. Then the RN, then the charge nurse, then the head nurse, then the nursing supervisor. Okay? Those follow your chain of command. It's very unprofessional not to follow that chain of command. It gets very iffy if you know that the nurse manager is your next door neighbor and you phone a friend and you don't give that head nurse the chance to respond to what the problem is. Basically, what you will see is that organizational charts are visual representation of the chain of command. They show you what the organizational hierarchy is, but sometimes you will see that that does not reflect the informal structure. I.e., that nurse that's been a leader on that unit for 20 years, that's not the head nurse or not the charge nurse. Those are the people that often you will see people go to. But what you're going to see is that if that person is very responsible, they should say, have you talked to the charge nurse about this? I think you need to talk to the charge nurse to see. Make sure that if someone comes to you with a problem that's not your job, ask them if they followed that chain of command. Just an example of what that is. All right. These are line responsibilities. When there is a solid line, that means that that's the way the work flows. Staff nurse reports to the nurse manager. Nurse manager reports to the chief nursing executive. This acute care nurse practitioner has this dotted line responsibility. That means there's a staff responsibility. That means that this person is an advisory role to this person. But what about here? That means that this nurse practitioner does report to the chief nursing executive. Now, nurse practitioners are going to have a little bit of a problem because they got to two bosses. Because they sort of are a nurse, but their reports are licensed by the physician board, they would have to report to the chief medical officer as well. Okay? Look at your organizational chart to see what your chain of command is. If your person that you usually report to is not available, then you move up the chain of command and figure out who you should report a particular item to. Okay, questions? All right, as I said, I'll be available at 1 o'clock.